So if you can just pull up the slides, your computer, just do it that way tonight. All right, so tonight we'll talk about now assessment procedures with preschool children and school-age children. All right, so the big question with young kids, okay, do you think would be what, as far as the main diagnostic question that you would want to know from the little child that you're evaluating? For starting.
When did it begin?
Okay, so we want to know when did it begin.
If it's really a fluency disorder and not anything else.
Right. So going back to not last week, but the week before that, we talked about what is stuttering-like dysfluencies, okay, and what are dysfluencies that happen in children's language development that are considered still dysfluencies, but they're not stuttering-like dysfluencies. Remember that information. So review for me what are stuttering-like dysfluencies. Prolongations. Mm-hmm.
Syllable.
Okay, syllable repetitions.
Whole word repetition.
Say that again.
Whole word repetition.
Not in itself. So that would be considered a non-stuttering-like dysfluency or a language-based dysfluency, though someone who stutters could also do some whole word repetitions if it's not in itself a characteristic.
Blocking.
Blocking, right? So cessation of sound, right? Cessation of phonation. All right, so we did prolongations, syllable repetition, blocking.
Tense pauses.
Tense pauses, so a lot of tension, right? You're seeing an effort in producing speech. And maybe one last thing. Besides just syllable repetition, what else could the child repeat?
Part word.
Part word, right? Or even just individual sound. So, okay, good. So what are considered linguistic-based dysfluencies or non-stuttering-like dysfluencies?
Interjection.
Overuse of interjections. Mm-hmm. Revisions, right? Mm-hmm.
Yeah. What was it? This projection.
So what are examples of non-stuttering-like dysfluencies? So linguistic-based dysfluencies that young children demonstrate.
Someone said projection.
Interjections, yeah.
Mm-hmm.
Mm-hmm.
The
Whole word repetition, yeah. Mm-hmm. Yeah, so you got most of them. Stops and starts could be. So they would stop and then start again speaking. So that's also a characteristic. And again, it's interesting because I have one client here at the clinic that we treat for some very mild language delays. And the mother reported to my student yesterday that she continues to feel that he stutters. So again, just to reinforce that, this seems to be coming up more often when I'm working with children with language-based delays or impairments. because this child's demonstrating those language-based disfluencies that we just mentioned, okay, but is not demonstrating any stuttering-like disfluencies, okay, but the mother feels he stutters, so she uses even that word. So we have to do more parent education, on what truly stuttering is, but just as another example that it's going to come up, in different cases that you have, and with kids who have some issues with expressive language, you're going to see oftentimes those non-stuttering like disfluencies, and some parents may be concerned that it is stuttering. Okay, so some equations here, some calculations you can make now to reinforce if a child is stuttering or not. Okay, more than 3. So anytime you see in the slides SLDs, okay, that means stuttering like disfluencies. So more than 3 stuttering like disfluencies per 100 syllables. So we're looking for that number or higher. We're looking at the number and rate of repetitions. So repetitions of sounds, repetitions of syllables. Clustering of stuttering-like disfluencies. So what does that mean, clustering of stuttering-like disfluencies?
Putting together, how close they are.
Yeah, so one characteristic of someone who has a stuttering disorder is that when they stutter, it happens in a cluster. So it happens over several words, sentence or two, and then they might be able to then be fluent for another sentence or two, and then they'll stutter again. So it happens kind of in clusters, is what they're saying. We want to look at the child's reaction to their fluency disruptions. Do you want to close the doors?
Yeah.
And obviously the concerns of the parent. So when working with children, it's extremely helpful to get videos, okay, of the child speaking at home that the parent takes. Okay, so you ask the parent, get their permission if they could take a video of the child speaking at home during instances where they're disfluent, and be able to share that with you, okay, as part of the evaluation. Why would we want the parent to do that?
It's a child in like a natural environment, so you can really get a general idea of how they are with even a comfortable person, how the disfluencies come about.
Right. And so, yeah, so we're getting a picture of them in their natural environment, and in their natural environment, right, they'll tend to be more representative of their communication skills. And you're also getting an idea of the communication situation as well. So what's happening during that time? What are they talking about as well? What's the communication demand? What are the parents asking them to say or discuss as well? So yeah, the goal is to get a 300 to 500 word sample in 2 or 3 settings is considered to be reasonable when you're doing an assessment. So we want to count the frequency of the stuttering-like disfluencies. over the total percent of the syllables that are spoken. So you're counting the number of breaks, okay, over the entire sample, okay, and you're getting like a percentage. Okay. You're also noting the types of fluency breaks, okay, so we want to know not just how many times this is happening, but we want to know what type of stuttering-like fluencies that you're seeing, okay. Indicators of awareness. So we want to know how much the child is aware of what's happening with their speech. And going back to some of the research that says children as young, again, as 3 and 4, when it first starts happening, they are aware. Okay, so years ago, it was assumed that if you couldn't really see some visible emotional reactions to the stuttering or disfluency, then, oh, Johnny's okay. It doesn't bother him. But now, through more research, they understood that children are aware that they're taught differently, okay? And it may still be upsetting or frustrating, but just because they're not having visible emotions yet, okay, about it, it doesn't mean that they aren't aware. So, with young kids who stutter, there still is a larger percent of a chance that they will recover on their own, okay? So they looked at the research of all the children who stutter at the preschool age, okay, there is a larger percent of kids who will recover and go into a remission and not stutter as they get older. Then there's a little bit smaller percentage than of children, typically males, okay, who continue into a chronic phase of the disorder. Obviously, working with parents, okay, during the evaluation process, okay, even if you are a school-based therapist, okay, I know, like, if you work here for the DOE, you still may be asked to do a evaluation for a child who stutters. However, the likelihood of them getting services are slim here in the city because it's considered a speech disorder. So, and most oftentimes there isn't a linguistic component, okay, to the child's impairments. So, services then are difficult to obtain through the Board of Ed if you don't have a co-occurring language impairment, okay, when you're receiving speech here in the city, okay, so, but many of you may not practice here in the city, okay, so you'll still have opportunity to still service kids, both evaluation and treatment, say, of a child who stutters in school, okay, so I worked with several kids in New Jersey in the schools for fluency, so.
Brooklyn and Manhattan where we can't?
Correct, all of New York City, yeah, Board of Ed. However, my client here that we see in the clinic, he still was evaluated through the Board of Ed. So the speech therapist still had to do a fluency evaluation. So it's not to say, oh, I don't need to know anything about fluency if I'm going to work with the Board of Ed. It's not true. But you just may not go very far with treatment. He did, I think, get like a 1 or 2 month trial of therapy that they funded. Yeah, and then we start to see him here. So obviously, you know, with any client that you're evaluating, you're going to need the participation of parents, okay, any child, you know, so regardless of that. However, because of the multi-dimensional elements, okay, of stuttering, okay, and also the parents' emotional reactions themselves, okay, to the child having a stuttering disorder, okay, you'll want to obviously, get more information from the parents as far as their perspectives and their feelings about their child stuttering, and then build a relationship with the parents that then you'll have going forward then into treatment. So, slide 4 lists primary concerns of parents that are very common. They may ask you, is this going to continue? When will it stop? Will treatment cure them?
What do you say to them? Yes.
No. So, with any disorder, again, this is not like stuttering specific, right? That will never make guarantees with treatment. We can be, I use the word hopeful of progress. Use those words. That you can say the prognosis looks good, that the child may be responsive to treatment if you try some things, and maybe in one of your evaluation sessions, and the child's responsive. So, but the big question is, we don't know, okay, which children in the pool of preschoolers are going to the ones go into remission or the ones who will stay chronic. Okay, we have some red flags, which I'll go through in a couple minutes, okay, of some kids who may show more of a chance of being into that chronic phase than others. But yeah, so I always tell parents, I don't have a crystal ball. I can't predict, how much progress your child will make, but they will make progress. Okay, there will be some change, so with treatment. What causes stuttering? Okay, so that's a big question the parents will ask. And now that we've done chapter 3, what do we think causes stuttering?
Could be genetic.
Right, so you'll want to ask when you do your intake information, the family history, and that is another indicator of the disorder becoming chronic or not. What else can be the cause? So what else could be causes of stuttering? That was ultimately determined last class.
I think we said something that the parents, without knowing on their own, used to put pressure on their kids. So that's another reason what could cause stuttering.
Yeah, so we know it doesn't cause it as far as a parent's interaction or responses, okay, to the child who's stuttering in their home. But we know, if they're putting added pressure, it's not helpful, okay, and it may make the stuttering worse, okay, and may facilitate it going into a chronic situation, but it's not the ultimate reason why it starts to happen. Yeah.
So it can't be like something severe trauma.
So
Or
one of the
injuries.
things that was mentioned is that a lot of times it's been identified that there has been some kind of stressful situation that's occurred around the time when stuttering starts to happen. So, so that could be one of the igniters, so to speak, to start the stuttering to start to happen. But so we said genetic, maybe a stressful event or situation.
Injuries to the brain?
Was it like one of the brains is like size is like weaker than the other?
Yeah.
The connections.
What?
The left side? Right side? I don't know. Left is language, I know that.
Right. So what's happening sometimes with people who stutter?
Like the improper connection between like vocals and
Right. Okay.
The neurophysiological.
Yes.
All the stuff that I
So, what causes stuttering would say the parent is a neurophysiological problem. In that, Gabrielle said, but we don't say Wernicke's a Broca's area to a parent, okay? Because they're gonna be like, what? So we don't want
people.
yeah, we might alarm the parent. Okay, we don't want to use a lot of medical terms, okay, with the parent. But we might explain it more simply in that, how do you think maybe, Gabrielle, you could explain it better to a parent?
Like I don't know.
Any other of you?
Isn't it like Broca's is on one side of the brain and Wernicke's is on the other, and there's like not a cross? Like
Right, so we can explain that could happen in, possibly happen in a person who stutters, is that they have more development on the right side of the brain, okay, than the left, which in normal speakers, all of our language production areas of the brain, you can use it kind of like that in more general terms to the parent, okay. In normal speakers, it's all focused on the left, but there's been some research that there might be a mismatch, okay, in that, you know, your child might be using a little bit different parts of the brain than, you know, other fluent speakers, okay, so, but yeah, explaining it from simply, okay, from a neurophysiological standpoint, that it has a neurological basis to it, but besides having that we call it cerebral asymmetry, okay, so that again has been more pronounced in adults, okay. With kids, we said that also what other parts of the brain are involved in coordination of speech production. Okay, so the midbrain, okay, so we can explain to the parent and say, besides, you know, the lobes of the brain, you know, just be kind of general, that the middle parts of the brain, so, which, you know, help us coordinate our movements, okay, and also filter out nerve signals to our, we say, you know, voice box, I'll use like general terms, lips and tongue to formulate sound and speech, okay, that signal can be a little, can be distorted, okay, so and not as we find, there could be a pause, okay, in the signal, okay, so there's a speech disruption, okay, so you can explain it in that way to a parent, as some of the more recent research to indicate that there are some, we say, neurological differences, okay, in the areas responsible for speech production, okay. Yeah.
What about for the 10% of people who have their language on their right side? It would just be the opposite? Like it would be the same concept? Because I know there's like 90% of people have their language on the left hemisphere.
Right.
But there's still that 10% on the right.
So that 10% they have stable areas developed on the right.
Mm-hmm.
But we're saying that there's asymmetry with people who stutter where, we said Wernicke's could still be on the left, but Broca's is on the right. Do you see there's not, you know, so that's what they're saying is happening. Okay, so just a couple other questions. Okay, how long will therapy last? And it goes back to what I was saying, will therapy cure? Is there a cure for stuttering? Will therapy cure my child? Okay, so I kind of explained some of the responses that you should indicate to parents. But again, you should be positive and hopeful with therapy. It's not to say that you should be kind of negative, saying, oh, we don't know, but just say, like I said, you know, that we can't predict the exact outcomes, okay, of therapy, but we know therapy does help children. Okay, so be something how I would word it. So there again, a lot of counseling goes involved with the parents initially, okay, and teaching them about the stuttering disorder, and that helping them understand that stuttering isn't a bad word, okay, and the sooner they accept that their child right now is stuttering, okay, that will help the child, okay, in the fact that the child will not have guilt and shame and feel bad that they're stuttering, and that it's okay what's happening, okay, and that it's nobody's fault, okay, meaning that the parents may have guilt. Maybe you did identify when you were talking with them that there was some kind of traumatic experience or something, and then the parent might feel guilty that that happened and they caused the child to stutter, something like that, but emphasizing that in life you can't control things, okay, and things happen, and it's no one's fault, okay. Okay, so we explained onset and development, and the neurophysiological models. There's also the demands capacities model that we talked about last week, okay, in that the linguistic demands for that child, okay, in that year that the child starts to stutter, or months that, it's starting to occur, the linguistic demand for that child is high. Okay, and there might be pressures and competition to speak, and that pressure and demand, okay, is higher than physically they're able to produce speech and retrieve the words and speak fluently. So that's the other model that's important to explain. Okay, so like I said, you may briefly get into some of the therapy, okay, that's involved. You'll be honest with the parent to say, that what therapy can do, okay, like I said, it can truly benefit children by being in therapy, but like I said, it may not eliminate the stuttering altogether. And there is variability in stuttering disorder. So in the fact that I mentioned, I think last class, that my client OP's mom mentioned when he started again in the fall semester, I think we might be turning a corner. I hardly hear him stuttering, but now it's a different scenario again, that we're midway, and Alexandra mentioned maybe it's school, okay, kind of like adding more stress as the school year goes on. So it's important to be honest with parents about what therapy can do for the child, and that we can help them manage, okay, their stuttering events, help them learn how to speak in a different way that enhances fluency or helps them speak more effectively, but it still may not stop the stuttering from happening. So again, some statistics we kind of reviewed here, but again, that recovery rate they cite is being 75 to 85% by age 6. Okay, so like I said, it's a high. So the thing is with this, it affects, I think, parents' concern maybe, and I guess need for their child to get therapy at a young age. And I think that, so the thing is with this is that some parents may just hope that their child will outgrow it because, oh, most kids outgrow it. We'll just, carry on and just hope it goes away. So the thing is, though, your child may be in that 25% where they become chronic, and then they've gone for years without treatment or ability to manage stuttering, which happened to my particular client here. Okay, they did a wait and see, okay, during preschool, and by the time then he was going into first grade, okay, then he's reached after 6 age mark, and he went into the chronic phase. Okay, so the more recently they're saying here with chances of remission, you have higher chance of having remission if that happens in the first 6 months. So if a child starts stuttering and then within 6 months it goes away. So that is a better sign that the child will outgrow it than if it lingers for several years. Okay? Okay, so besides just doing like a percentage of how many times the child stutters over your entire syllable sample, okay, you can look at a weighted stuttering-like disfluency. So in slide 7, it gives you an equation that you can do to look at so you're adding together the number of part word and single syllable word repetitions per 100 syllables, okay? And then you're multiplying that sum by the mean number of repetition units. And then you're dividing that by the number of words where this occurred. So you're kind of focusing in on all of the stuttering events, okay? But then you're giving more weight to what in that equation? Are we giving more weight to part word or single syllable word repetitions, or are we giving more weight to repetition units? Yeah, so you're looking at overall sound repetition. So you're kind of getting more of a picture, okay, of true repetitions versus other. They're saying with young kids that they tend to have more repetitions than blocks or prolongations. So that's why they're kind of focusing more on the events of repeating units. Okay, however, now it goes on to then slide 8. If a child then has blocks or prolongations, okay, then that's multiplied twice. So that's given even a little more weight. So if you have a young kid who's also, like I said, it's not as likely, but it can happen, okay, if they're also blocking and prolonging, so all of those things, repetitions, blocks, prolongations, if they're doing all of that, then you're going to get a higher number, okay, than if you just have a child who just does some sound repetitions. Do you see that's how you're kind of getting a picture of what, as far as the stuttering like disfluencies, what's worse, okay, what's happening in the child's profile. So if you get a weighted stuttering like disfluencies of 4 or above, so the number is getting 4 or above, and also associated non-speech and psychosocial characteristics. So child's awareness, okay, negative attitude about communicating, struggle and escape behaviors, all of that then is indicative of a true stuttering disorder. Yeah.
Do you need to memorize it?
You don't have to memorize it, but be aware of this equation as one method, okay, to evaluate a child who stutters, a younger child who stutters.
I'm bad at math.
Yeah, No, I'm not going to ask you to recite the formula, but know of the formula that you can go look it up and use it, okay? Or know that this exists. Okay, so other criteria that was identified by Contour in 2001. Some more, again, statistics. Frequency of disfluencies is greater than 10%. Scores, now I brought in some assessment tools that we can take a look at. The stuttering severity index is one that I'll show you, but it kind of gives you a reference here that we want a score of 19 or greater. Clusters of stuttering we mentioned, okay, constitute 25% of the child's disfluencies. And again, stuttering has been occurring for 18 months or more. So that's what we want to know, how long this has been happening.
Professor?
Yeah.
Is there one specific criteria that, like, I forgot what the insurances wanted, like for coding, is there a specific way to diagnose it? Or you can just go by like an equation and find the 7 criteria?
Yeah, so it'll be up to you as a clinician of what method of assessment you choose to use. Maybe you use the criteria by Contour, or you want to do the weighted SLD along with, though it's score of 4 or higher, along with the non-speech and psychosocial characteristics. So yeah, it's up to you as the clinician of how you are assessing the child, okay? And then all your data, information that you gathered from the assessment, then you are then making the diagnosis, okay? So then, depending on what the outcomes are, if you feel the child is stuttering, okay, then you would use the code for fluency disorder or child onset fluency disorder if you were billing the insurance.
Okay, but they don't require like one specific criterion reference, like looking at them just to see, okay.
Yeah, no. The stuttering severity index is very popular if you want to have a criterion reference. But no, insurance, they're not nitpicking on like what you do, okay, in your assessment. It's that you did an assessment and that you're coming up with a diagnosis. Okay. All right, so some behavioral characteristics that you want to be aware of when you're doing an evaluation or as you're progressing with treatment is that some of the indicators that the child may be obviously aware, but then having more anxiety, okay, related to speaking, okay, is head and eye movements associated with stuttering event and or right before the child stutters. They may avert their eye gaze. They may look away. They may have some secondary characteristics, or they might have some head nods before or during the stuttering moment as a secondary characteristic. There may be changes to their voice. So pitch rise, schwa substitutions, that's inserting the schwa vowel, the sound, when they're doing repetition. So if it's bus, it's bus. Right? So I'm doing the fear and avoidance behaviors. And if the child is demonstrating any decrease in their willingness to speak or engage in any activities that require speaking, the child's kind of refusing to participate or engage in. So there are some published assessments. Okay, they're not formal because they're more checklists, so I brought some up tonight. We'll take a look at them. One centered on younger children is called the Kitty Cat, and that's a communication attitude test for preschool and kindergarten children who stutter. So along with your calculations of how often stuttering is happening, you also want to look at the child's reactions, okay, and their emotions and feelings related to their stuttering. And you want to use some of these other profiles or published checklists, okay, to also examine that as well. Because we said the actual stuttering event, okay, is what in proportion to the overall stuttering disorder? So the actual
The tip of the iceberg.
right, okay, it's the very small part, okay, so that's why, it's never appropriate to just calculate how often stuttering is happening, okay, you really have to look at the other reactions, okay, with the family and also the child's reaction to when they stutter, okay. All right, so there's other characteristics associated, a lot of times they've determined among children who stutter, that there could be some other kind of mild, like neurological kinds of characteristics that may co-occur with the stuttering disorder. So I know specifically with my client OP that it's been reported he has trouble attending in school, and specifically during structured tasks, during literacy tasks, and those kinds of classes where you really have, the information is a little dry, history, those kinds of classes where you have to pay attention. And
How old is he?
He's 9 years, 9 months, so 9.5. Yeah. So here, 36% they determined children who stutter also have attending disorders. They also have speech motor coordination difficulties. There's also a high percentage, okay, of different temperamental characteristics, like having high self-expectations or being overly sensitive.
Or having high expectations.
High self-expectations, like perfectionist kind of personality. And I know, again, with my client OP, falls into that kind of category. Right? Other kinds of things that can happen in the environment, okay, or from other people in their, children in their lives, their family members, people at school, okay, that they have a disruptive communication environment. Okay, so 61% of children they determined have some type of disruptive communication environment. Secondary gains, meaning that the child is excused, okay, for speaking situations. They can kind of manipulate themselves out of some uncomfortable situations. And obviously we know that there is a higher chance of them being susceptible to teasing and bullying in school. All right. So slide 16 gives you kind of a summary, of the kind of red flags, okay, of a child having a stuttering disorder. So we talked about the genetic component, though it doesn't always have to be, okay. Yes, there's a high likelihood that there's someone else in the family does stutter, but again, my client OP parents said repeatedly, we don't know anyone in our family who stutters. So it doesn't always have to happen that way. And even when I asked my father about it, he's like, I cannot remember anybody who stuttered either. So, it's not always. Okay, so it's important to obviously get the parents' take on what's happening, and oftentimes, when they do say their child is stuttering, like I said, I've explained, yes, I haven't seen anybody say their child is stuttering that they haven't been disfluent. But again, you have to figure out, is it a language-based disfluency, or is it truly stuttering-like disfluencies? So that's what you have to filter out. Okay, if we do a weighted stuttering-like disfluency score, again, a 4 or greater, and stuttering increases when communicating under pressure. We're going to see tense movements of the head, face, and neck. And there's psychosocial reactions to stuttering. You may see then the child changing their participation levels in activities that require speaking. You also may see, again, some personality characteristics where the child's upset by changes in routine, or they are kind of unusually afraid, of strangers, or really do not like interacting with unfamiliar people. So just some interesting research that they determined that recovery and persistency are inherited. So if you have a parent reports that, oh yeah, my brother stuttered also, but he stopped when he was 6. Okay, so then if, that parent is bringing their own child in because they're stuttering, then they have a higher chance of recovery just because the uncle did in the family also recover. All right, so some other indicators that a child will more likely grow out of stuttering, okay, is, again, if the child is female, okay, so we know that they have a higher chance of remission. The child is, if they're younger and it starts to happen, and they're saying less than 3 years old, there are few relatives who stuttered, so if there's less genetic influence, and like I mentioned, if relatives did stutter but they recovered. We want to see then over time that there's a rapid decrease in the severity of stuttering. So the parent may come to you and say, like maybe they had to wait a month before they saw you for an appointment or something, and they may come to you and say, I recommended Johnny to get evaluated because 2 months ago he was stuttering so severely that I was so concerned, but now he's not stuttering really at all anymore. So those kinds of comments, even though there's a variability in stuttering, if the parent gradually sees a real drop off, then that's another good sign. Okay. So what you want to watch for are, we say red flags to a child going into a chronic phase, okay, of stuttering, is that they're male, okay. Over time, there's little or no decrease in the weighted stuttering-like disfluencies over a year, okay, after it begins. So it's when over that first year that the stuttering has first been identified, that's when you really have to watch and see. Like I said, if there's a gradual drop-off, okay, during that year, then that's a great sign the child's going to outgrow it. Okay? But during that 12-month period of when it starts, to then over that 12 months, if you're seeing no decrease, okay, in the stuttering-like disfluencies and the occurrence of it, then that's more of a concern. So, increase in, again, part word repetitions, faster repetitions. So the repetitions occur faster. And there's more secondary behaviors, okay, like head and eye movements. And the stuttering-like disfluencies start to happen in clusters. So that's where you want to be more concerned. All right, so getting into now specific tools we're going to use now to assess children. All right, besides some of the equations that I've mentioned, the weighted SLD, looking at the 7 characteristics, okay, we can also look at using some scales, and one of them, I'll just show you, it's in your book, is here. So on page 176 in your book, just take a look at this assessment tool by Andre and Guitar, and it's the A19 scale for children who stutter. So it also goes into more questions, okay, to the child, such as when the teacher calls on you, do you get nervous? Okay, so more of the psychosocial and how stuttering is affecting the child's life.
176.
Yeah, so 176, 177, it goes over to 178. So take a look at that as another tool, okay, besides just doing the number of stuttering-like disfluencies, okay, to get a take on what's happening there. Okay, so some of the behavior assessment batteries, yeah, I brought those up that we have downstairs. So the speech situation checklist, okay, is downstairs in the clinic, and here they ask the child, how is your speech? Is speaking difficult for you? Does it happen to you? Does it often happen to you that the same sound or same word comes out over and over again? Okay. So they kind of go through a rating. How is your speech when you, for instance, talk with a new kid in school during dinner? Okay, so different situations. And then the child would say, I have no trouble or very much trouble. So you go through the series of questions, how is your speech when I tell a story? So you kind of get the idea, okay, the different situations here. So same situations, okay, but now the checklist is now emotional reaction. So how is your speech? Same thing. And because of your speech, are you afraid to now talk during dinner? Okay, so then not afraid, very much afraid. Okay, so these are good tools to really delve into what the child's thinking. Hopefully they're giving you honest answers. Sometimes I feel when I've done some of this stuff with my client OP that he's giving me a lot of answers I want to hear and not necessarily, but I think if the children are younger, they're more honest. Yeah. And they're not getting used to hiding things as much. Okay. So, but yeah, but it's still helpful because even though, like I said, at times maybe my client OP hasn't been completely forthcoming, when I do ask him every session about how the week was going, some weeks he may say it's been okay, but then in particular last week he said I had a really hard time when I had to read in class. Right? So you know, no matter what, I think the child will divulge to you, you know, but it may take over some time and maybe some treatment sessions, you know, that you'll find more out than just the initial checklist. But like I found, these questions are still good to use from a therapeutic standpoint to kind of monitor what's happening weekly with the child, and if there's new situations that are coming up that they're afraid to speak, and different areas of communication that maybe you should be targeting, okay, with the child. So this is the speech situation checklist. We also have the OASIS. Okay, so I think they mentioned this. Oh yeah, I did a last slide. I mentioned the OASIS. So again, the OASIS, meant for older school-age children. Okay, so the other speech communication checklist you can use for younger kids, okay, but the OASIS is meant for age groups 7 to 12, 13 to 17, and then also even for adults. Okay, so it's very popular. It stands for the Overall Assessment of Speakers' Experience of Stuttering. So, and it goes into a little bit more detail. Like section 1 here asks general information. How knowledgeable are you about stuttering? Okay, so again, that's why it's for older kids, a little bit older kids. And what happens with your speech when you stutter? Okay. Some other questions. Overall, how do you feel about your speaking ability? As some examples. Your reactions to stuttering. When you think about your stuttering, how often do you feel helpless, angry, ashamed? Okay. Yeah, so that actually has come up with my client here when we've done outings. When I mentioned we go out to Smashburger or somewhere. We've come back and we kind of like do a debrief, kind of how did that go? How did you feel? You know, and he's mentioned that he gets angry, okay, when he can't be fluent. Okay, so so it, you know, it's there, you know, so it's you know helpful that this is addressing some of those feelings. Anxious, I know my client also has communicated that as well. Embarrassment. So this goes into a little bit more specifics about the feelings scale that I showed you. What I'll do is copy this and scan it, maybe next week. So you can take a little look at this a little bit more detail. Since I can't kind of go item by item in class, okay, but it's important for you guys to be aware of this one as far as examining kind of the overall experience, okay, of the person who stutters with the OASIS. So, all right, so the other last thing I'm going to show you is, then, like I said, the stuttering severity index here, okay, and this is kind of, you know, like the go-to standard, you know, for assessments in stuttering. And basically what you're doing is in different speaking tasks, okay, you're still coming up with the percent, okay, of stuttered syllables, so SS, as they stuttered syllables, so you're still coming up with that percentage. You're doing... for kids who can read, you're doing a reading task, and then you're doing like a novel speaking task. Okay. For non-readers, you're just doing 2 different speaking tasks. Okay. You're also charting how long the stuttering events occur. Okay. So that also gets a score. Okay. You're also then evaluating any kind of physical concomitants, so secondary behaviors. Okay. And then you're adding then a score for that, okay? And then you're adding the frequency of stuttering, how long the stuttering events happen, and physical concomitants. Then you're getting here a percentile, which then equates to severity. Okay, so it's pretty straightforward, okay? But what is the stuttering severity index missing?
Motion.
Right, okay, so you can't just do this, which I see some clinicians do. Give this. But you're missing the whole aspect of the child's psychosocial effects of the stuttering. You're missing, you know, their reactions to stuttering events. What are they doing when they stutter? What kinds of situations, okay, are they avoiding or having negative feelings about? Okay, so that also needs to be evaluated with those other more behavioral assessments, checklists, okay, that I mentioned, like the OASIS or the speech situation checklist. Okay. Those we have here in the clinic. Okay, any questions? Yes.
So, for example, if we're doing an eval, we just would combine like SSI and OASIS.
Yeah, or, you know,
The one in the textbook.
Yeah, you could do the one in the textbook. Yeah, I mentioned the A19 scale by Barry Guitar, or the speech situation checklist. Yeah, because we want to know where the child's having the internal struggle, okay, because then we want to address that in therapy, okay. We don't want to just address the thing, and this is kind of bridges when we get to therapy, okay, that our therapy isn't just addressing the stuttering, okay, you're also addressing the other psychosocial elements, okay, of the disorder as well, and that's why it's important to do these checklists, okay. All right.